All right, let's dive into a topic that's absolutely critical for any orthopedic trainee, slipped capital femoral epiphysis, or as we all know it, SCFE. This is one of those diagnoses that gets missed way too often in kids. And the consequences of a delay, well, they can be absolutely devastating. So what we're going to do here is give you a solid framework, a system, so you can confidently nail the diagnosis and management of this condition, both in your exams and out there in clinical practice. So what are we really talking about here? At its core, it's a fracture right through the growth plate, specifically through its weakest link, the hypertrophic zone. You can kind of think of it as a Salter-Harris type I fracture, but it's got its own unique twist. And here's the key thing to wrap your head around. The ball part of the hip joint, the epiphysis, it actually stays put in the socket. It's the neck of the femur, the metaphysis, that displaces forward and rotates out. That's the classic deformity we need to identify. Okay, so picture this. An adolescent walks in. Maybe they're overweight, probably male, and they're complaining about pain in their hip, thigh, or even just their knee. Your brain should immediately be screaming SCFE. It has to be number one on your list. Obesity is, without a doubt, the biggest risk factor. And hey, a little pro tip, if the kid is younger than 10, or kind of unusually they're underweight, you've got to start thinking about an underlying endocrine problem like hypothyroidism. Now, let's move on to how these patients actually present and what you need to be looking for when you examine them. Now, this slide, this is huge. This is the single biggest trap in diagnosing an SCFE. Get this. Up to half of these kids show up complaining only about knee pain. It has nothing to do with the knee. It's all referred pain coming down the obturator nerve from the hip. And this is exactly why so many cases get missed. The kid gets sent home with the diagnosis of a knee sprain, and we lose precious time. You'll often find that the story is a bit vague, kind of chronic. They've had this limp or this dull ache for weeks, maybe even months, before they finally get to you. But when you get them on the exam table, the absolute dead giveaway is a loss of internal rotation in that hip. It's crucial, and you always have to compare it to the other side. And that brings us to the pathognomonic physical sign for SCFE. If you're going to know one sign, it's this one, the Dremen sign. You absolutely have to know this for your clinical exam. In your Viva, you can't just drop the name. You have to explain why it happens. It's not just a party trick. It's all because that prominent part of the metaphysis is now bumping up against the rim of the hip socket. When you can explain that mechanism, it shows you really truly get what's going on. So you suspect SCFE based on the history and exam. How do you confirm it? Let's move to imaging. Okay, you have to get both views of both hips. No cutting corners here. Why? Because this thing can be bilateral in up to half the cases. Plus, you need that good side for comparison. And remember, that lateral view is your best friend for catching a really subtle slip. Oh, and if you think it's an unstable slip, get a cross-pable lateral instead of forcing a frog leg. You definitely don't want to make things worse. All right, let's talk about maybe the most famous line in pediatric orthopedics, Klein's line. It's super simple. You just draw a line along the top edge of the femoral neck. In a normal hip, that line should slice off a little piece of the femoral head. If the head looks like an ice cream scoop falling off the cone and your line misses it completely, well, that's a positive Trethewin sign. And this isn't some newfangled idea. We're talking about a paper from way back in 1952. Even then, they knew that this simple line was the key to an early diagnosis and the key to preventing a lifetime of crippling arthritis. It was a huge deal then, and it's a huge deal now. Now, if you really want to impress your examiners, you'll mention the 2009 modification by Green and his colleagues. The classic yes or no Klein's line, well, it can actually miss up to 60% of cases. The modern approach is to actually measure the amount of the femoral head that's sitting lateral to that line. If there's more than a 2 millimeter difference between the two hips, that's highly suggestive. It just makes the whole thing so much more sensitive. Klein's line is the star of the show for sure, but don't forget about the supporting cast. There are other signs that can back up your diagnoses, especially when it's not super obvious. The metaphyseal Blanche sign, for example, is just a fancy way of saying there's some increased density on the AP view because the two parts of the bone are overlapping now that one has slipped back. Right, so you've diagnosed it. What's next? Section 3, classification and prognosis. This is so important because it's going to dictate everything we do from here on out. Okay, listen up, because this is probably the most important classification we're going to talk about. It all boils down to one simple question. Can the patient walk on it? If they can, even with crutches, it's stable. If they can't, it's unstable. And an unstable slip is a flat-out orthopedic emergency. Why? Because the risk of the bone dying, avascular necrosis, or AVN, just skyrockets. We're talking from less than 10% to almost 50%. It's a total game changer. Then we have the Southwick slip angle. This is how we actually put a number on how bad the slip is. You basically measure the angle on the lateral X-ray and compare it to the other side to see the difference. This gives us our grade, mild, moderate, or severe. And that number is what's going to help us decide exactly how we're going to tackle it in the operating room. Which brings us to Section 4, treatment principles. So let's talk about what we're going to do. The goals here are pretty straightforward. We need to stop it from slipping any further and try to avoid any nasty complications. And rule number 1, as soon as you diagnose it, that patient is not putting any more weight on that leg, period. For the vast majority of these slips, the go-to gold standard treatment is percutaneous in situ fixation. Basically, we're going to put a screw in it. And usually just one big screw is all you need. In fact, using just one screw actually carries a lower risk of AVN than using multiple screws. The technical goals are super clear. Place one screw right down the middle, perpendicular to that growth plate, get a good bite into the epiphysis, and do not poke it out into the joint. So that raises a really interesting question. We know up to half these kids can end up with a slip on the other side. So, should we just pin the other hip while we're there? Well, it's a bit controversial, but yeah, there are some clear high-risk situations where it's definitely the right call. So who are these high-risk kids? Well, if the patient is really young, like under 10, if they have one of those endocrine problems we talked about, if their pelvis is still growing, or if they're an obese male. If your patient is ticking a few of those boxes, the chance of the other side going is pretty high. And that's a conversation you need to have with the family about maybe pinning it just to be safe. Now remember, putting a screw in just holds things in place. It doesn't fix the deformity that's already there. So what do you do if that healed slip leaves a big bony bump that causes pain and impingement down the line? You've basically got two main options. For milder cases, you can go in and just shave down that bump. That's called an osteochondroplasty. For the really severe slips, you might need a much bigger operation, a proximal femoral osteotomy, where you actually cut the bone and realign the whole thing. And finally, these are the major complications we're trying to prevent. AVN, the bone dying, that's the big scary one. Chondrolysis, where the cartilage just melts away, is thankfully rare now, but it's often caused by an errant screw poking into the joint. And of course, long-term impingement and the slip just getting worse because the fixation wasn't good enough. This is why getting it right matters so much. So let's bring it all home. What's the number one takeaway? It's simple. You have to be suspicious. Always examine the hip in any child complaining of knee pain. Just thinking about SCFE, just having it on your radar, that is the single most important step you can take to prevent a lifetime of hip problems for these young patients.